everyone. Thank you for being here. Sorry for the delay, we had some technical difficulties. My name is Laura Vanos, and I'm an embryologist at IVF Spain Alicante. And the topic of today is selecting embryos for better success. Embryologists are the people in the IVF team who are responsible for manipulating the egg cells and the sperm cells. Also for taking care of the embryos during their development and for taking care of the culture conditions. And eventually, we're also the people who take decisions about the embryo. So, for example, every day we have to decide whether embryos have enough quality to be considered viable, and if it's worth transferring them or preserving them. And we're also the people who give grades to the embryos and assess what their quality is in relation to the implantation chances that we believe these embryos have. So today, during this webinar, we would like to share a little bit of our knowledge with you. You know that this is an interactive presentation. So if you were to have any questions, you can make them through the button of Q&As. These questions will only be seen by the presenter, and of course you can also make some questions through the chat section, which will be viewed by all the viewers. So with this little introduction, we are going to start. When the computer allows me. Okay, sorry for that. So what we're going to speak today about is embryo selection. So what we refer when we speak about embryo selection is actually, as you probably know, during cycles, patients retrieve many eggs. And our job as embryologists, when we have all these embryos, is to know which embryos are viable and which ones not. Because obviously we only want to transfer the ones that can lead to a viable pregnancy. And we know that a lot of the embryos that are produced cannot actually lead to a viable pregnancy. So the tools that we have as embryologists to evaluate this embryo quality, the main parameters that we study are embryo morphology, embryo kinetics, and embryo genetics. Embryo morphology refers to how the embryos look like at each point of the embryo's development. So during the stages of embryo development, we will just basically look at the embryos and score certain characteristics that they have. Embryo kinetics refers to the timings of divisions of the cells in the embryos, meaning that, for example, some embryos divide faster, others divide slower. Some have chaotic divisions, while other ones have very synchronic divisions. So this is what we will be studying through embryo kinetics. When we combine both, so we take into account both how the embryo looks like at every point of its development and what these timings of division are, we would be speaking about morphokinetics. Finally, the third point will be that we use to select embryos will be embryo genetics. This has become very important in the latest years. Not every embryo is molecularly okay. So the embryo may look perfectly fine on the outside, but still have anomalies that will prevent that this embryo leads to a successful pregnancy. So in the latest years, more and more we are analyzing embryos to see their genetic component content, their chromosomal content, to see if the embryos are normal and can lead to a viable pregnancy. And by doing this, we can make the time to pregnancy shorter. So starting with the second point, kinetics. To study the kinetics of an embryo, we need time-lapse systems. Time-lapse systems are incubators that have cameras inside of them. And these cameras take pictures of each embryo around every 5 minutes. In the end, we have video recordings of all the embryos. The benefits of these systems is that each patient has an individual chamber for their embryos. This provides very stable culture conditions on one hand, because it's never necessary to open and close the doors to take out embryos of other patients, because only one patient will be in this chamber. And on the other hand, because we can look at the embryos just by looking at them on a screen. So it's not necessary to take them out and place them under a microscope. On the other hand, from the videos that we get from the embryos, we get enough information to the morphokinetic analysis of the embryo. For example, we can see if the embryos have or not direct cleavages. We speak about direct cleavages when cells, instead of dividing from one cell to two cells as they should, divide from one cell to 3 cells or to many cells. We can also see if the cell cycles are synchronous, if the divisions happen timely, and what the duration of the cell cycle is. With these markers, we can predict the implantation potential of the embryos. There are special algorithms that are designed for this. And this allows us, among a pool of embryos, to select the best embryo for transfer. In this slide, we can see the main timings of embryo development. As you know, the day of the egg retrieval, when we collect the eggs, the same day we will inseminate the eggs with the sperm. So the fusion between the sperm and the eggs will happen on this day. And around 17-19 hours after this insemination, the next day in the laboratory, we will evaluate if the embryos have fertilized successfully and how many embryos have a normal fertilization. So a fertilization with 2 pronuclei. Usually on this day, we'll contact patients to let them know how many eggs were retrieved, how many were mature, and how many have this normal fertilization. And these are basically the embryos whose development we will follow. On the first day, the embryos have a single cell, but then they will start dividing to 2 cells, to 4 cells, 8 cells, 16, 32, 64, and so subsequently. At day 2, we will evaluate the embryos between 41 and 45 hours after the insemination, and at day 3, around 70 hours after the insemination. There's a point in the embryo division where the borders between the cells are no longer visible, and the embryo becomes sort of a compact mass. This is called the morula stage, and is usually reached on day 4 of development. We do not assess embryo quality on day 4 of development because this morula stage is very difficult to assess, and it doesn't give us a lot of extra information. So there are not many parameters that we can look at on day 4. What will happen to this morula is that at a certain point, a cavity will appear, and this cavity will be filled with fluid. This cavity will grow and grow, expand and expand, until the embryo reaches a very particular structure, which is what we call the blastocyst. This is the viable embryo that can lead to a pregnancy, and this stage is reached between day 5 and day 6 of development. We can assess the quality of blastocysts in a broader range between 110 and 134 hours after insemination. These times at which embryos are assessed may vary from one laboratory to another one, also because the timings of embryo development may be slightly different depending on the culture media that is being used, and also depending on the culture conditions. The time of the day at which you will look at the embryos also really depends on how your laboratory organizes itself and at which time the egg retrievals take place. So we have spoken about the embryo kinetics. Now we're going to speak about the morphology, so how the embryos look like. On one hand, we assess the embryos in a way on day 2 and day 3, the first stages of development, but we assess the embryos differently when they have reached day 5 and they have turned into blastocysts. So we're going to speak about these 2 ways of assessing embryos. On day 2 and day 3, what we will look at is the number of cells that the embryos have and the degree of fragmentation. Good quality embryos on day 2 should have around 4 or 5 cells, and good quality embryos on day 3 should have around 7-8 cells. It is true that these have been traditionally the categories that we consider optimal, but very often on day 3, we see embryos which are developing a little bit faster. So they have around 10, 11, 12 cells. And when the divisions have been synchronic with no direct divisions, they can still be of very good quality. When the embryos are too slow, usually this is a worse prognosis, but still sometimes, for example, embryos on day 2 who only have 2 cells with no fragmentation can be viable embryos, which can eventually reach the blastocyst stage. Regarding the fragmentation grade, we classify this with grades from 1 to 5. An embryo with grade 1 fragmentation would be an embryo with 0% fragmentation, with no fragmentation at all. An embryo with grade 3 fragmentation would be an embryo with around 10 to 25% fragmentation. An embryo with grade 5 fragmentation would be an embryo with more than 50% fragmentation. Fragments are pieces of cells that the cells lose when they divide, when they split. They are not important components of the cells, but the problem is that when an embryo has a lot of fragmentation, this will be an obstacle for the embryo to reach the blastocyst stage, because these little pieces are making pressure and do not let the embryos evolve in the way they should. We usually consider that the grades 1 and 2 of fragmentation are embryos of good quality. Grade 3 and grade 4 would be embryos with lower quality, and embryos which have a degree 5 of fragmentation most likely will not be viable. Next, like we say, we will speak about blastocysts. Blastocysts are these structures that are reached on day 5, day 6, and they are composed of the following parts. First, as you can see in the image, we have a compact mass, which we call the internal cell mass. This mass will become the future baby and is surrounded by a layer of cells, which we call the trophectoderm, and will become the future placenta. The cavity filled with liquid is called the blastocell, and the whole structure is surrounded by a shell that the embryo has from the beginning, which is called the zona pellucida. This zona pellucida becomes thinner and thinner as the embryo grows and expands, and at a certain point, the embryo will break it and will come out of this shell to be ready to implant. Not all embryos have the same quality, so we consider that we grade embryos according to their expansion rate, the internal cell mass quality, and the trophectoderm quality. And the expansion rate, for example, goes from 1 to 6. Blastocysts with an expansion degree 1 are early blastocysts that have barely grown at all. And then blastocysts with a grade 4 of expansion would be blastocysts with a really thin zona pellucida, blastocysts which have grown a lot. Then we would have expansion grade 6, which would be hatchet blastocysts who have come out of the shell completely and are completely ready to implant. Regarding the quality of the internal cell mass, like we said, this will become the future baby. We know out of experience that it is important that it has a minimum quality for obvious reasons. The internal cell mass should be compact, round, and clearly visible. We consider that embryos that have A and B qualities for the internal cell masses have good quality. Embryos which have a D score will never be considered viable, never be transferred or biopreserved. And in the case of internal cell masses with quality C, generally speaking, most times we will not consider them viable, but there are some exceptions depending on the history of the patient and the overall quality of the embryo. So we will have to see case for case. Then we have the trophectoderm quality. This should be a cohesive layers of cells, and like we said, it will become the future placenta. When the trophectoderm has quality A or B, we consider it has good quality. When it has D quality, it has degeneration signs or very few cells, we would never consider it viable. And when a trophectoderm has quality C, we consider it has less quality than average, but still acceptable. So our job as embryologists is to select the viable embryos, and a very important tool that we have in the laboratory for this is extended embryo culture. So leaving the embryos in culture for several days, in particular to day 5, day 6, is a very powerful tool that we have to make this distinction and to choose the best embryos for transfer. And we're going to see 2 clinical cases where we will try to explain this a little bit better. So in the first clinical case, we have a patient who had 9 embryos which were correctly fertilized, and 9 embryos which had a normal fertilization. We left these embryos to divide for the first 3 days. And the resulting embryos are the ones that we can see in the pictures. When we used Morphokinetics to grade these embryos, we saw that, well, we would score 6 of the embryos with a grade A, 1 of the embryos with a grade B, and 2 of the embryos with a grade C. And if hypothetically we had to choose an embryo for transfer on the 3rd day, it would be a little bit difficult in the sense that we would have a lot of embryos to choose among, so 6 embryos in this case, and not very significant differences between them. So we would have, so to say, a wide range of embryos to choose between. What happens if we leave these embryos in culture until day 5? Well, 4 of the embryos that we have given an A score, so the best score, did develop successfully into blastocysts, into viable embryos. In this particular case, the patient transferred 1 and froze 3. However, 2 of the embryos that we had given an excellent score failed to reach this stage, which means they were not viable. This means that if we had to take this decision on day 3, in 1/3 of the cases, we would have taken the wrong decision. And next to that, it's easier for us to select the best embryo out of the 4 at the blastocyst stage than it is on day 3. So as you can see, it is easier for us to select an embryo on day 5, and we have also more information about the embryo. Here we have the second clinical case. In this case, the patient had 4 embryos that were fertilized successfully. When we left the embryos to divide to day 3 and we graded the embryos, in this case, we found we had 1 A quality embryo, 2 B quality embryos, and 1 C quality embryo. In this case, if hypothetically we had to choose an embryo on day 3 for transfer, the choice would be clear because we have 1 embryo which stands out and which has the best quality. So we let the embryos to divide to day 5 and see what happens. Well, in this case, for these particular patients, none of the embryos were able to reach the blastocyst stage. None of the embryos turned out to be viable embryos that could lead to a pregnancy. So as you can see, especially in this case, it was very important for these patients to find out that they had this problem. If we had transferred the embryos on day 3, this would have only led to disappointments and waste of time. So I think it shows very clearly an example of how more information is provided when we culture the embryos for a longer time. And this brings us to the 3rd point. We have talked about how we can select embryos by leaving them in a long culture, by looking at them, by studying their kinetics. But like we said in the beginning of the presentation, it is still possible that even though the embryos look perfectly fine, inside they are not molecularly okay. As you can see in this graph, the number of euploid embryos are genetically normal embryos, fall a lot dramatically when the female age is higher than 35 years old. So especially for patients where the egg age is very high, we recommend to test the embryos genetically to find out if they have the right number of chromosomes or not. If we transfer an embryo which is not molecularly okay, it will not lead to a positive pregnancy test, we will not implant, and very often also it can lead to early miscarriages. So the idea of testing the embryos, especially for this population of patients where we know that the number of, or the percentage of abnormalities is going to be high. This tool can be very useful to try to shorten the time to pregnancy and to avoid transferring embryos that are going to give a negative result. This technique is called PGTA, and to perform it, what we do in the laboratory is to biopsy the embryos. So first, we need to wait until the embryos have lots of cells, until they are expanded enough. And when the time comes that they have reached this stage, what we will do is aspirate a few cells with a pipette and loose them up with a laser. It is important to say that we take the cells from the trophectoderm, so not from the actual baby, but from the tissue that surrounds it. We never touch the baby, okay? These cells, we put them in a tube, which are sent to a genetic laboratory, and in around 10-20 days, they send us back a report that we give immediately to the patient so that they can start planning their embryo transfer. So as a summary, the key of our success rate, the reason, the tools that we have that make us have good results are embryo culture until day 5 or day 6. Of course, optimal culture conditions. We need to mimic the conditions that we find in the uterus and control the quality very closely. The morphokinetic analysis of the embryos, which provides us a lot of additional information. And very important, PGTA testing to find out which embryos are genetically normal and which ones not. And the take-home message from this presentation is that it is important to have as much information as possible about the embryos, because IVF cycles or embryo transfers can fail for many reasons, and not all of them are related to the embryos. There can be blood coagulation problems, there can be receptivity problems, there can be immunological problems, and all of these problems can be treated. There are treatments for them. But in order to know where to focus, we need to rule out that the problem lies in the embryos. So it is important for diagnosis, for knowing where to focus and knowing which treatment you need to receive. But it is also important not to waste time and avoid transferring embryos which are not going to have a positive result. So this is the end of the presentation. I hope you enjoyed it and that it had some useful information for you. We would like to take the opportunity also to remind you that we'll have some patient meetings, online patient meetings between 24 and 27 September in the online fertility show with a doctor from our team, Dr. Izquierdo. So of course, feel completely welcome to participate if you have any questions that you would like to discuss with an expert. So right now we will start answering the questions that you have been making throughout the presentation. I can see there are already some. Thank you for the great webinar. If some embryos by day 5 still haven't developed into blastocysts, but may in day 6 or later, do they have fewer chances to lead to a successful pregnancy? Actually, this happens really often, so that they reach the blastocyst stage on day 6. And these embryos we know completely for sure that they can lead to pregnancies. Perhaps the euploidy rate might be a little bit lower. It's controversial, but in any case, these embryos can definitely be viable. If they take more than 6 days to develop into blastocysts, or for example, if they take 7 days, which rarely happens, but sometimes it does, these embryos can also lead to viable pregnancy, but the chance is much lower. So I hope that answers the question. Does pre-implantation genetic diagnosis PGD on day 5 increase the success of IVF? Yes, definitely. It definitely does increase the success chance. We do in our clinic, we are really specialized in this, and every day we're biopsying embryos And yes, especially like I said, for this group of patients, this subset of patients who have a very high likelihood to have a high percentage of non-euploid embryos, it will help a lot, on one hand, to find out if this is the case or not, and also to save time not transferring embryos, which can lead to miscarriages and which can lead to failures of implantation. So eventually you will create the same embryos. It's not that you will create more or less embryos because you do PGD, but you will select better the embryos that you're going to transfer. And sometimes it can also have an important diagnostic value. What is the success rate with donor egg cycle? The success rate with donor egg cycle, of course, is much higher than with your own eggs. At least, of course, if you fall between among the group of patients that has this indication, right? Who doesn't produce embryos anymore, or who doesn't produce embryos of good quality. And the success rates are very high. Of course, this will depend on which category of patient you are, which age you have, which problems you have, which uterine problems you have. But generally speaking, we can say that after a program of egg donation, 80–85% of patients will have a baby. So, is it true that higher levels of medication used for stimulation could lead to worse egg quality? This question I would prefer to leave to the doctors because it's not my area of expertise. Of course, when you work for a long time in an IVF clinic, you hear a lot. But yeah, since it's not my area of expertise, how the medication can affect the egg quality, I wouldn't dare give you an answer. I think it would be better that you ask this to one of our doctors. Like I said, we have a patient meeting very soon, and perhaps it can be a good question that you can that you can make them. I do know that doctors very often, if patients come with a history of stimulations that did not go very well, one of the strategies can be to change the dose of medication, of course, but whether higher levels of medication will lead to worse egg quality, I would not dare say. Yes. So, would you recommend doing PET if you only have one embryo? Yeah, that's a very good question, because during this presentation, I was speaking a lot about how these tools are useful to select embryos among a pool of a lot of embryos, right? But actually, all of the things that I have mentioned are also useful, even if you only have one embryo, to have a diagnosis, right? Obviously, if you only have one embryo and it's not possible that it reaches the blastocyst stage, or it's not euploid, you will eventually not have an embryo transfer. But many times this is better, and to know why, than to be endlessly transferring embryos with fake hope without knowing what is going on. So yes, it can definitely be worth doing PET if you only have one embryo. It's not a technique that we will recommend depending on the number of embryos that you have, but more depending on other circumstances like your age and your previous history. Is there any disadvantage or contraindication of PET? Disadvantage or contraindication of PET? The only thing is that embryos need to have good enough quality, so we need to have a high number of cells so that we can biopsy them. So we've had cases, it does not happen a lot, but we've had 1 or 2 cases where these really slow developing embryos, so they were embryos that would have reached the blastocyst stage on day 7. And we preferred to call the patient and let her know we thought it was necessary to cancel the PET because the embryo did not have enough cells to be biopsied. So there are a few cases where this has happened, but generally speaking, if the embryo is at the proper stage, the biopsy is completely safe. This is not a problem at all. And I think there are many more advantages than disadvantages when it comes to PGT technique. Can you please explain what aneuploidy is? Okay, so to make it simple, during the webinar, I was speaking about genetic quality. But really, what we can see with PGT is like you ask if the embryos are euploid or not. So embryos should have the 23 pairs of chromosomes that every human has. But as you know, there are some diseases like Down syndrome or Turner syndrome, to put the most famous examples, where the individuals do not have the right amount of chromosomes. So for example, they have 3 times the chromosome 21 instead of 2, okay? So this is what we can test through PGT, and this is the meaning of euploidy. It means having the right amount of chromosomes. So what we can test, if you have the right number of chromosomes and exclude all the diseases that result from not having them. Reason for slowly growing embryos. Yeah, this has to do with the metabolism of the embryos, because on one hand you have the genetics and on the other hand you have the metabolism. So sometimes this happens in eggs which, if they are really slow, perhaps eggs which do not have so good quality, but it can also be that at the time of microinjection, they were slightly more immature eggs. For example, we've had eggs which matured in vitro from the moment of the egg retrieval to the moment that they were microinjected, developing a lot more slowly. So that could be a reason. And it could also be a quality problem, that the metabolism of the embryo is not so active. Is there any possibility of fragments getting reincorporated back into the embryo during compaction? I don't think this happens very, very often. It is true that something that sometimes happens is that the cells are going to divide and then finally they don't, or they fuse again. This is called reverse cleavage. But as much as the embryo, the fragments compacting and getting reincorporated back into the embryo, no, I don't think so. Usually what happens is that the embryo leaves the fragments out, and you can actually see them in the blastocyst. You can see how the blastocyst forms, and it's surrounded by a layer of fragments, which is pushed against the shell. But these fragments stay in the shell when the embryo breaks free, actually. And one more. Thank you very much for the presentation and precise explanation of the answers. And thank you for your questions. Our case, 11 eggs extracted, 10 matured, 9 embryos. Only 3 of them were considered to be sent for PGT. Quality 6 PB. And all of them came as aneuploids. Are these percentage common? Mother age 39 and AMH over 3. Sperm tested of good quality, and all tests so far are fine. Well, yeah, for maternal age 39, you are indeed reaching that point, right? Close to the 40s, where the euploidy rate for some cases will not be very high. It is true that there are patients above 40 who produce euploid embryos. We see that, but it is something very, very individual. It depends from each person. So these percentages, yes, they could be yeah, they could be found at patients in 39 years old, definitely. Yes. It would be good to know a little bit more about your case, right? Like if this was the first cycle, if this is always your pattern when you have a cycle. But it is a pattern that, yes, we could find in a 39-year-old patient. It's not that it is impossible to have euploid embryos at that age, because we do see people at that age who produce euploid embryos, but there are also some patients who don't. I see there are some questions in the chat section. Are day 6 blastocysts better than day 5? embryos with one deletion in PETA, can we transfer it? So embryos on day 6 better than on day 5, it depends. Sometimes, for example, you have embryos on day 5 that are already blastocysts, but perhaps the next day when you go and look at the embryos that were too early on day 5 to be frozen or to be transferred, they have expanded a lot, they look beautiful, and actually they look better at that moment on day 6 than the embryos you had on day 5. So it depends. I think sometimes there can be embryos at day 6 that are better than the embryos you had on day 5. Generally speaking, it is a good sign that the embryos reach the blastocyst stage on day 5. So it means they have a very active metabolism, are developing really well. But for example, when we are doing PET, we want to make sure that the embryo has a lot of cells before we biopsy it, because we don't want to harm the embryo during the biopsy, and we want to take a few cells that we can analyze safely. So sometimes we will wait a little bit, right, until we can biopsy the embryo, but it does not mean that the embryo was not able to reach the blastocyst stage on day 5. So careful about that. Sometimes embryos on day 6 can be as nice as embryos on day 5. And embryos with one deletion in PETA, I understand by this that you mean that there is one chromosome missing, so that one of the pairs only has one chromosome, and no, this cannot be transferred. This cannot lead to a viable pregnancy or healthy pregnancy. Which causes involves when no fertilization seen during ICSI? Okay, when no fertilization is seen during ICSI, as an embryologist, we can see different things the next day when we say no fertilization. We can see eggs that degenerated. We can see eggs that did not activate, for example. We can see eggs with too many pronuclei instead of 2. This will tell us a little bit what might be happening. For example, with very bad sperm quality, something that we see often is that the eggs did not activate. So it's like as if ICSI had not happened. This can be sometimes related to the sperm. If the eggs have membranes that offer no resistance, if after microinjection we see degeneration, this is often related to the egg quality. The same with multipronuclei. This is usually related to the egg quality. There are also some cases where there are failures of activation that do not so much have to do with let's say there are patients who have particularly failures of activation, and this can be solved with calcium ionophore, or at least improved. It's a tool that we have in the laboratory that has been successful in some cases to try to improve these cases of failure of fertilization. It also depends a lot on the number of eggs that you have, because, for example, if you have 1 or 2 eggs and neither of them fertilized, well, it's a low fertilization, but you only had 1 or 2 eggs, so it could happen. If you have, for example, 8 eggs that did not fertilize, this is very strange, right? So it probably will have to do either with the egg quality or the sperm quality. Yes, exactly. Day 6, better you, yeah, like I said, this is controversial, and it will also, so sorry, I didn't read the question aloud, but recent studies say that day 6 have better euploidy rate than day 5. So this is controversial because there are studies saying one thing and another study saying other things. Probably this depends also on the criteria that your laboratory has to decide to leave an embryo in culture until day 6, sorry, or to cryopreserve it or transfer it on day 5, because depending on this criteria, you will have, your samples will be different, and this could probably affect the results. In any case, if an embryo is euploid on day 6 and an embryo is euploid on day 5, in this case, we can assume that they have similar qualities, right? We can assume that if both are AA embryos, let's say, and they have the same expansion degrees, we can assume that they have the same quality. We were told that after day 6, they would not reach the blastocyst stage. At which point do you see that they are not going to get to blastocyst? That's a good question, and this is something that we sometimes have to explain to patients. Very often at day 6, you can already see that these embryos are not viable, right? This is usually the case. If an embryo is not good, you can see it at day 6, because the problem is not that it didn't grow enough. The problem is that it has a lot of degeneration signs. Degeneration means dying signs, okay? The cells are blackish. The trophectoderm has very few cells. The inner cell mass is barely visible. This means that this embryo is not viable. It's not going to lead to a viable pregnancy. And this we can clearly see on day 6. It's not necessary to leave the embryo to day 7. But there are a few cases, it does not happen very often, but sometimes, where it's not that the embryo has terrible quality, it's just that the embryo is forming a blastocyst, which looks nice, but it's very early, okay? It's not the stage that you would expect for a day 6 embryo. So this is the only case where it would be worth to leave the embryo until day 7. That said, if this happens, you can already imagine that the pregnancy chances for that embryo, even if it reaches day 7 with the proper stage, are very, very low. So probably if they told you at your clinic, at your laboratory, that after day 6 they would not reach the blastocyst stage, could be because they saw that the embryos did not have good quality, or it could be, yeah, probably because of this. Yeah. So yeah, I see. Okay, so here we have some other comments. I myself am an embryologist, and I have seen the experience of clinicians play an important role in embryo development. Do you have the same experience? No, not really, in the sense that I mean, of course, the way you, if you have a good stimulation, right, where everything is going fine, and then, yeah, everything has been done in the proper way, you will have a better prognosis, right? This is super important. But I would say, since we work in pretty standard conditions, I mean, as an embryologist, for example, the hands that manipulate the eggs or the sperm or the embryos, if people who are doing this are experienced, I don't think we play such a big role. Obviously, speaking in laboratories where the conditions are very controlled, where the training programs are very controlled, and where the people who are working are experienced. Yeah. Yes, obviously the stimulations are very important. I agree on that. Okay, so thank you very much for your questions. I don't know if you have any more. This was a very interesting dialogue with a lot of interesting questions, I have to say. So thank you very much for your comments, and thank you very much for participating and for making it so interesting. It was really lovely. So I hope if you have any more inquiries, or if there is anything more about your particular cases that you would like to discuss, that you feel free to contact us and join us in one of our patients meetings, or yeah, that we can help you in the near future. So thank you very much for your attendance, and yeah, this will be the end of the presentation.